today we are organizing a lot of events, and I would like to introduce our president of Nepal Epilepsy Society, Dr. Basanta Pant, to come and share his experience in the management of epilepsy and the future of its treatment in Nepal, and what we have been doing for the past many years.
We did the first epilepsy surgery in 2020. First temporal lobectomy in a young male. Surprisingly, he's seizure-free for the last 20 years. He never had seizure after our surgery for the last 20 years. And he's a big businessman in Pokhara now. So we have more than 180, I've not counted it correctly, but about 180 epilepsy cases till date. And recently we started doing more and more complicated cases. Just like yesterday we did, this is the third ant lesioning in Nepal.
I'd like to call upon Dr. Manik, he's our FCPS resident, to talk about the controversy and new frontiers in epilepsy surgery. He has made a small presentation.
So good morning, everyone. Happy International Epilepsy Day. I'm Dr. Manik, neurosurgeon resident here at Annapurna Neurological Institute of Applied Science. So I'll briefly go through today's presentation, which is like medical refractory epilepsy. What are the controversies and new frontiers in epilepsy surgery? Let me start with saying the theme for 2024 International Epilepsy Day is by sharing your opinion or advice about what are the obstacles you have faced, and define your expectation and discover unexpected courage and resilience regarding the epilepsy journey. So when drugs do not work, but we need to know what are the drugs currently prescribed for epilepsy surgery, epilepsy patient. There are more than 38 drugs currently approved for treatment of seizures or epilepsy. If you look at the graph here on the side, if we prescribe first drugs for seizure disorder, 37% of patients will respond adequately. If we add second drugs, more 13% will be added, and if we add third drugs, 4% more improvement will be achieved adding third drug. So basically that means if we add 3 or more drugs and the seizure control is not adequate, then we can consider that as a drug resistance epilepsy or seizure disorder. Since 1800, there has been more than 38 drugs developed for treatment of seizures. However, the percentage of response is quite shocking, which is like only 32% has adequate, 70% has adequate seizure control, and 32% will develop seizure and drug resistance epilepsy. And this was an article published in 2022 in the Journal of Neurology, American Journal of Neurology, where they have mentioned about the referral gap from drug resistant epilepsy to those who has enrolled into epilepsy surgery, from 100,000 to just going up to 3,000, which is quite a shocking. Probably there's a huge gap we need to explore more, involving neurologists, neuropsychiatrists, and neurosurgeons. And once the medication does not work, then what are the alternatives to anti-seizure medication? Some advice for dietary changes, including keto diet. There are some devices which has been used to control the seizure, and some surgical treatment which we'll discuss in detail. There are currently 2 types of surgeries we perform for epilepsy, which is one is curative and another is palliative type. In curative, resection of the lesion can cure seizure. Sometimes ablation of foci can also result in seizure-free patient. And there are some palliative measures, which is like stereotactic ablation using RFA, gamma knife, focus ultrasound, and neuromodulation, including VNS, DVS, and RNS can be used in terms of surgical treatment in epilepsy. And, to consider neuromodulation in epilepsy, we need to consider epilepsy surgery as a circuit-based surgery. Mainly 3 circuits are involved: circuit of Pepys, cerebral circuit, and basal ganglia has been explored extensively. Today, we'll more focus on the circuit of Pepys, especially anterior nucleus of thalamus and centromedullary nucleus of thalamus. There has been more than 19 devious targets for epilepsy, including anterior nucleus of thalamus and centromedian nucleus, which has been extensively researched and approved for treatment of drug-resistant epilepsy. And some of the unusual brain targets for devious in epilepsy can also has been explored, and some of these are familiar tracks, and some of these areas are unfamiliar in terms of neuromodulation, such as posterior medial hypothalamus and cauda zona incerta, which lies in the same plane. So thalamus stimulation or lesioning as a target in DVS, the criteria for patient to enroll in this kind of neuromodulation is those who have more than 1 year unsuccessful seizure control despite 2 anti-seizure medication chosen appropriately at appropriate dose, and not a candidate for surgical resection, and seizure foci involving eloquent cortex, multifocal or generalized seizures, not adequate seizure control after resective prior surgery as well. We need to understand anatomy and function of anterior nucleus and centromedian nucleus in epilepsy. There has been mounting evidence which implicates that thalamic centers are involved both in genesis and propagation of epileptiform activity across the brain. In 1941, thalamus was proposed as centralized area from which EEG waves could pass out to both hemispheres, resulting in LOC. Centrocephalic seizure, as they were termed, were believed to originate principally from the thalamic nuclei, which used to show prototypical spike waves, recognized as an absent seizure critically mediated by thalamus. And it has been thalamus has been divided into two parts, limbic part and reticular part, which has significant potential for neuromodulation target in medical refractory epilepsy. So anterior nuclei being serve as a primary hub for limbic thalamus, which implicated in secondary generalization of temporal lobe seizure through PAVE circuit, and reticular center, which primary nucleus of reticular center is centromedian nucleus, which forms the major relay center for ascending reticular system and has been implicated in frontal and generalized epilepsy, particularly in Lennox-Gastaut syndrome. So this was a paper published in 2022 by where they have explored anterior and centromedian thalamus anatomy and function, as well as dysfunction in epilepsy. One of the pioneers in centromedian nucleus stimulation is Dr. Francisco Velasco from Mexico City, who has enrolled and published this paper in 1987, which has been a long time back. He had 49 patients with a follow-up period of 6 to 15 months. The results show significant improvement in seizure control for generalized tonic-clonic seizure, atypical absent seizure, and was less efficient to control complex partial seizure. And deep brain stimulation for centromedian nucleus appears to be safe and efficacious treatment, particularly in patient refractory to generalized epilepsy. RNS has also been played role in new frontiers. Like they have studied a patient who has stimulated the anterior nucleus of thalamus, and a closed loop RNS system was deployed, where 4 patients with the drug resistance seizure were readily detected in centromedian region of thalamus and used to trigger closed loop thalamic stimulation that dramatically reduced seizure frequency and severity. And anterior nucleus of thalamus, this is the main relay center of PAVE circuit, as we discussed before. Erwin Cooper was the one who believed that the role of anterior nucleus of thalamus is in terms of epilepsy and disrupt in limbic system seizures. How we can target the anterior nucleus of thalamus? We can obtain the image in 1.5 to 3 Tesla MRI. They have also compared the listening of anterior nucleus of thalamus into 2 groups, stimulation versus listening group. In these 2 charts, we can compare the stimulation group has 21 to 100% seizure reduction, whereas radio frequency ablation group has 17 to 100% reduction in seizure over a period of 3 months to 6 months. And these are the location and coordinates for entered nucleus of thalamus. 5 to 6 millimeter lateral to in x-axis, 0 to 2 millimeter anterior to mid ACPC line. In z-axis, 10 to 12 millimeter from mid ACPC line. There has been broad range of ACPC coordinates reported in Sante trials, but as we discussed, the average lies in 5 to 6 millimeter lateral, 0 to 2 millimeter anterior to mid ACPC line, and 10 to 12 superior or cranial to mid ACPC line. The main target in the anterior nucleus of thalamus is outflow tract pathway from anterior nucleus, which exists in lateral border by enterothalamic radiation, and that has shown more efficacy compared to other region of the anterior nucleus. And the approach or targeting for anterior nucleus of thalamus can be achieved through transventricular route versus extraventricular route. In this paper, they have compared the accuracy and targeting through transventricular is better than the extraventricular trajectory. So the surgical consideration when targeting the anterior nucleus of thalamus, we need to consider septal veins, thalamostriate vein, superior choroidal vein, as well as choroid plexus, which is close vicinity to the surgical window in anterior nucleus of thalamus. And laterally also, if we go slightly laterally, we can encounter a thalamostriate vein. So we have to have narrow, we do have narrow surgical window to target the anterior nucleus of thalamus. There are 4 key anatomic structure we need to identify, which can be obtained in 1.5 Tesla and 3 Tesla, which is anterior nucleus of thalamus can be visualized directly through imaging, and mammothalamic tract or internal external medullary lamina of thalamus, as well as surrounding veins. This was our case where we performed left anterior nucleus thalamus lesioning. We did the CT imaging, and then we fused that CT image with MRI, which was done in DBS protocol to obtain our working coordinates. In this way, we set up a patient with surface electrode. Patient is awake, and once we record the pre-lesioning EEG, definitely we can see there is a discharge from F3 and C3, and this one is post-lesioning, where we can see there's a marked improvement in F3 electric activity compared to the pre-surgical pre-lesioning. So what are the controversy at current in terms of surgery and neuromodulation in epilepsy surgery? I think most of the time we think that curative surgery is only our goal, but reducing seizure frequency up to 50% can also improve quality of life and reduce the complication related to surgery, including SUDEP. And so neurologists or psychiatrists who will be evaluating seizure patient with seizure disorder or epilepsy should consider when there is a drug resistance, and there are more than medication that can help patient with seizure disorder. And anterior nucleus of thalamus has been new frontiers in last 10 years, and I think it will be more explored in upcoming years for treating and managing patient with epilepsy. To conclude my presentation, I think curative surgery is not only goal in epilepsy. Decreasing frequency and disabling seizure can also improve patient's quality of life. And we know that disease burden of epilepsy is more than combined movement disorder. However, number of surgery or neuromodulation performed for epilepsy is less. So we need to look for candidates who could benefit from surgical neuromodulation and intervention. And I think Neuralink is real thing, and probably it will give us more information regarding brain networks and how our brain functions. That might also help us to explore more about the neuromodulation in.
Thank you, Dr. Manik, for presenting a very nice presentation, and he has shed some light on the lesioning on anterior subthalamic nucleus for the management of status epilepticus.
So basically, ant lesioning and ant stimulation is exactly the same thing. This is our principle in movement disorder. This is our principle in other like psychiatric disorder. Also, we have started surgery on psychiatric disorder also. So whenever there is too much active focus, then you just go and destroy that area, whether by electricity or by heat. So if you put a DBS, it's very, very expensive, but if you just burn that part out, it does the same thing. Only thing is with DBS in epilepsy and in psychiatric disorder, I think there is a lot of modulation that is happening, and here we don't have that. And one of the interests that I have is why in Mexico and in Brazil, actually, Brazil is another country where they are more for centromedian nucleus targeting, whereas in Northern America and Europe, including China, they are more interested on ANT DBS. And another thing is BNS that we are doing, but we are not very keen on BNS because of it takes a long time for the patient to have some recovery, at least 1 year, and very expensive. It's an expensive device, but then technically very, very simple. But then we are using VNS in multifocal epilepsy and also, generalized epilepsy where we don't know what's going on. So in that case, now the ANT has come. If the problem is like anterior and temporal like this, okay, then centromedian and anterior works. But posterior seizure, there is no answer. BNS don't work, this technique don't work, and there is no answer. Nobody has any answer to this in the world till now. So these are maybe cerebral stimulation, I don't know. I don't have any answer. And about corpus callosotomy, we were discussing yesterday also, that we are doing corpus callosotomy complete, but there are some patients who are still having generalized seizure, and this is very, very surprising to me. So in the olden days, complete disconnection surgery mean anterior and posterior commissurotomy also included. Anterior and posterior commissure were also dissected out. So when I was looking at the fibers, then fork minor fibers is going at the base of the brain through the anterior commissure. So maybe if we do just corpus callosotomy and leave that part, maybe we are missing that, and then maybe that is the reason our patient. So maybe we have to go back to our old techniques in these cases and go and actually do the commissurotomy also. Then our patient will become much better. But fortunately, the cut mark benchmark is 50% reduction in epilepsy, then it's success. And in all the cases, whatever VNS or corpus callosotomy or now anterior nucleus thalamus, we have achieved this in all cases. But we are trying to have zero seizure or very, very few seizure. So these are pretty difficult yet. And lastly, epilepsy is dealt by neurosurgeon, mainly neurologist and also psychiatrist. So this is the place where we all come together. And this is the place where we should start thinking as a neuroscientist, not as an individual, but then collaboratively work together. And then we will start knowing so many things by, teaching each of us. Thank you.
Thank you, Dr. Pant, for sharing your knowledge regarding the management of epilepsy. And it has been many years that you've been treating epilepsy patients, from management, conservative management, reading easy, video easy, as well as localizing the lesion, and also performing epilepsy surgery and opening the frontiers in the management of epilepsy in Nepal. Thank you very much.